We should start the conversation.
Perfect. Well, Gary, thank you so much for doing this, and thank you for your leadership. Well, you know, but I'm going to say it again because I need to say it. I'm your fan. I think you are so kind to me, and then you've been my mentor. I'm so blessed to be working with you.
You should be live in a second. Oh, hold on. I'm getting feedback. Hold on. Sorry about that. Put us on to YouTube. If I can find it on my page. Hold on. Sorry. Go ahead.
Good. Okay. So we were discussing this earlier, and right now I've been seeing the patients with COVID for the past many weeks, and one of the conversations we started to have with everybody is, why are we seeing so many African Americans and in the intensive care unit? And so the ratios were so significant that it was concerning, and this is the experience across the world, across the country for sure, but other parts of the world we've seen some patterns as well. Like in England recently, they have started to look at that aspect as well. But in the US, it's very clear and very stark. And then that's when a lot of physicians and researchers have started to look at more detail. And then I think with you and your leadership and your work, it is worthy to have a much more detailed conversation. So I will, if you want, Gary, you want to say a few words, and then I can share some data and information with you.
Yeah, no, I'm very interested in the data you have. As you know, the Senate started off this pandemic doing daily calls. One of my roles, I guess, was to continue to bring attention to things I think had not been being done or seen in the Black community and Hispanic community of Connecticut. And some of the things I thought, if we didn't put in place, would lead to higher rates of infection in our community. So as I just sit here thinking about what your data is going to show and guessing what it says, I'm as worried as I've been this whole time. So I'm ready to hear what you have to say and do some thinking aloud with you.
Yeah. And I think after the conversation, we'd love to take some questions. And then what we could also do is look at the policy areas. If we cannot fix the policies after this pandemic in our state, then we can never do them.
Right.
I mean, it's going to take a global pandemic for us to wake up. I mean, people have been awake for a long time. People have been experiencing these challenges for a long time. So I would just start by saying that we are in the midst of a perfect storm for the minorities, but more so for the African American community with the pandemic. And I'll try to explain this in more detail. Connecticut is essentially part of this epicenter in the world right now. The death rate in New York, New Jersey, and Connecticut is the highest. So our case fatality rates, if you look at the case fatality rates of the number of people who have died in the state of Connecticut and the ones who are positive, and if you do the ratio, the case fatality rate is 8.8 or so, which is more than Italy. Everybody who has been talking about, oh, what has happened in Italy and so on. Connecticut is right up there above that case fatality rate. So this is a very, very significant issue for us as a state. And the rate of increase of the cases, if you look at how fast the disease spread in our state, it's faster than it spread in China, Germany, France, Spain, and Italy. So we have had a faster rate, number of patients have been more, and our death rates are high as well. So it's like, if you look at from that perspective, just as a state, we have been in trouble. Now we have surpassed the 3,000 deaths in the state, but these are the structural issues that we find ourselves in. One is that we are the fourth most densely populated state in the country. And then we are the sixth oldest state. And then we are a state from day one, from God knows for how long, we have the highest healthcare disparities in the country. We are a state with the richest of the richest communities in the country and the poorest of the poorest in the country. And the difference has been so stark that we have lived this. We have been fighting for this issue for a long time. And that's been there. And then on top of everything else, we have nursing home deaths that have been very high in our state. So you put these pieces of the challenge together, it's a nightmare that we are all experiencing, especially for African Americans. So the number of cases per 100,000, there are 315 per 100,000 if you are a white American in the state of Connecticut, or a Caucasian American. And if you're African American, it's 714 per 100,000, which is more than double the likelihood of that. So you're double as much likelihood of getting the disease. But if you look at the death rate, so Latino community before the cases, Latino are 610. So they are about twice as much that the Caucasian Americans to get it as well. The death rates per 100,000, if you are a white American, it's 55. Caucasian Americans are 55. The African Americans is 72. So the death rate is higher in the African Americans as well. So now we have in the entire state, we are above the rest of the country almost. And then within the state, the African Americans are right on the top with the chances of getting it, and the likelihood of surviving it is actually less for the African Americans. So that's the part. This is the Connecticut numbers, and we have other parts of the country which also have pretty bad numbers. And keep in mind, the African Americans are like almost 10% of the population in Connecticut, but the disease burden is very significant. If you look at Michigan, where African Americans are like 14% of the population, and they are 40%, 40% of the death, from 14 to 40%. And in Chicago, just the city of Chicago, 70% of the COVID deaths were of African Americans, 70%. And they make up about 30% of the population. So it's like the disease has been merciless, and the problems that we have had in the communities with respect to a number of factors have just been magnified to the point that this is basically, Gary, we've been talking about these challenges for the past many years. I have seen you speak about these issues of healthcare disparities forever, and you've been a leading advocate, not only in the state of Connecticut, but in the country on these aspects. Now, with what we are seeing right now, and I wanted to have the conversation first and foremost with you, is that, hey, Gary has been right from day one. And now we are seeing, the entire world is seeing what's happening in Connecticut, what everyone is seeing is there. And hopefully there will be a wake up at this point to say, look, we need to do more of this. I want you to reflect a little bit and say, and then I'll go more into the details.
Yeah, I want to thank you for reaching out to have the conversation, because I think what I've heard from the beginning of this from people is that there's been a revelation of sorts, right? People are now seeing things that they probably should have seen. I don't know how I feel about that. I've said in some venues that we've had revelations over time. And every time one of these revelations happens, what people say is there's a revelation and now things will be different. If you think about Hurricane Katrina and the thought pieces and all of the analysis, people said very similar things. And if you actually look at what's happened, we did not move in the direction that people wanted to move in. So one of the reasons why I'm so thankful that you reached out to have this conversation is because I do think that it has to be a thing where we continue the advocacy we've done, and we find new ways of making sure that we continue to talk about what these issues are, so that people with the ability to make a difference, including ourselves, but people with the ability to make a difference cannot say they did not know. The response of the federal government, and more specifically, and perhaps more importantly to the audience that I have and you have, the state government cannot be what it has been, to be as blunt as possible. If you think about what happens in the communities we're talking about, we have comorbidity like other communities, but comorbidity in our community means a different thing when it comes to something like COVID-19. So communities have issues of comorbidity. It just happens, right? You have whatever disease you have. but it's not necessarily a death sentence. The way that this seems to be flaking out is for communities of color that we are focused on right now. It is that. And so the question becomes, why is that? Some people have said things like, well, it has to do with these crises going on. And that, to me, is the point and the rub. It's not a crisis. This is the norm in these communities. And crisis is something that happens, it occurs, there's a response to the crisis, and the crisis ends. But the issues of housing that have plagued Black communities remain and will remain after COVID-19. Issues of access to healthcare have been and will remain after COVID-19. Issues of going to a hospital and getting disparate treatment. And I'm not talking about the treatment once you get into the hospital, I'm talking about whether you make it into the hospital or not, have been and will remain. And those are the things that become factors in why COVID-19 plays out the way that it is. So it is extremely important that that information, particularly the information on the rate per 100,000, because I think when you look at some of the other data, it doesn't seem as bad as it actually is. But when you look at that data, you have to ask the question, what is fundamentally different about these communities? Or what is fundamentally different about the structures that cause people to live in communities that function the way that they do?
Yeah, you're absolutely right. So as I was trying to frame this, and I divided the issue of the causation and so we know what the data is. We just heard about the data being so high and so on. But if we were to break it down, I divide into three broad categories. One is the spread, one is the disease progression, and the third one is the disease management. So spread of the disease, so we know this, that the African-American community is living in even more densely populated areas. If you look at the inner cities and you say, you know what, let's have social distancing. Great idea. How are you going to do social distancing when people are not able to be in more than one bedroom apartment? And if you look at in New Haven, in Bridgeport, in Norwalk, and Hartford, all these different parts of our state, and Stamford, you will see that social distancing is a great idea and it works. We know that, but it's not possible for some communities. It is not possible to be able to have social distancing and then be the frontline workers. You're more likely to be an essential worker if you are in the minority community. So you cannot be protected because you are in that situation. And then when you're at home, you don't have as many restrooms, you don't have as many rooms, you cannot be separated, you cannot quarantine yourself. And as a result of which, you actually can spread it to your families. And I have seen a young man taking care of his older mother, both of them got sick, deathly sick. And now there is a virus, but then there is a social environment which is a part of the disease. The virus is a virus that you don't control, but the social environment, that is something that you have an ability to control that. The policies are the ways to control that. I think that's what the part that is there, that how many people in the minority communities, in more so in the African-American, can do telecommuting?
Right, and I think when we think about this, right, this goes back to just the way the structures have been set up, which is why much of my conversation has been focused on structure, because look, we can't tear down the structures during COVID. We can begin the process, but we can't tear it down. So a lot of what we're seeing is in place, and what I believe needs to happen is people who are responsible for the response need to listen to the communities. The communities know what they need. And to be honest with you, I'm not sure that's what's happening. As I look at the response to Connecticut, I don't see enough people who can connect into these communities as a part of what's going on. And I said this on a Zoom call last week. What you see are, if they are present, people who look like those communities, what you see is they're part of subcommittees, but there's usually a decision-making committee where they don't sit. And so it's good to be a part of the process in some way, but it's better when you have some say over what the outcome is going to be, some say over what that output is going to be. And if you look at Connecticut right now, and I don't know how far you want to go down this road, but if you look at Connecticut right now, and the fact that there's a consulting group that's been brought in, I believe that that takes you further away from community response than even what we were already doing.
Yeah, yeah. I mean, the consultants are by definition people who are paid big money to tell you what you already know.
Right. And given and, yeah, and given the fact that none of us have been through this before, I really don't even understand the notion behind bringing in consultants when you sit in a state that has all kinds of institutions of higher learning with people who do epidemiological work, who do work on social structures, all of the things you actually need sitting right in the state. But I don't want to go too far down that path. But it's just to say that the response and the direction in which we go gets further removed from the community that knows best how that community is set up. With all due respect to the governor, he just fundamentally cannot understand how these communities operate. It just doesn't make any sense whatsoever that he could. He's never lived in a community like this. Most of the people he knows don't come from these communities. So you need ways to understand those communities. And it's not by putting people on a subcommittee somewhere who are the people you put on other subcommittees with all due respect to them, but it's by having a different conversation and having different people brought into the conversation that's being had. And when people's representatives bring to bear the conversations they're hearing to actually listen.
Yeah, yeah. So now as we're looking at the one factor is the density of people living in some of the communities, inner city communities would have, you cannot distance themselves. The other thing is that there are a number of diseases that we are seeing in the communities, but those are again social disease. And I'll explain to you what that means. Look, everybody knows we're supposed to eat healthy, but make that into reality if you're living in some parts of our state. There are food deserts which are a reality. Trying to get fresh food, trying to get healthy vegetables, fresh vegetables, and then healthy food in some of the inner cities. And then in one town, you can pay a lower price for the same food as opposed to another town, which is the inner city areas, the cost is so much more different. So it's almost like a engineered way of making sure that junk food or poor quality food or unhealthy food is easily accessible in some communities versus the others. And
Right.
this is structural challenge that we have had, and that's why we are seeing the look. I've been in the past as part of Connecticut Health Foundation. When I got elected, I did not continue on in that role because you, as an elected official, you cannot be. So but one of the things everybody's been talking about is why healthcare disparities. Like, for example, in Hartford or even in New Haven, you have these great hospitals, they're doing great work, and these communities right around those hospitals have the worst health. And
Yeah.
it's a, you're closest to the biggest centers and the best centers, and how come your health is bad? This is the secret. The secret is the opportunity of healthy living is not equal.
Right. And
That is the problem.
when I think of health, I don't think of health because I'm in a hospital, right? I think of health
Yeah,
as all of the all of those things that keep me from being in the hospital, right? Access to good
yeah,
food, the space and the air. I mean, when you think about the communities we're talking about, there are many issues within the housing that they have, and just in the air. When you get
yeah,
outside of the housing, the particulate rate in these communities is significantly higher, and so it is not like it happened in a way that was planned. It is a thing that happened because of plans that were made. Government has made certain decisions that have allowed for these things to happen. Government zones, government sets up schools, government has a hand in all of these things. And yes, we all have choice, but that choice is made in the context of what government has decided to do. And so
yeah,
when you look at COVID-19, it is revelatory, but it reveals not just that there is a difference, it reveals all of those structures that have been in place for a very long time. And the role that we must, if we haven't done this, we must take up is the role of dismantling large portions of that. And when you say something like that, that seems extremely radical to people. What do you mean? You're talking about dismantling, right? Like you can't be dismantling things. But if you're going to have a change for these communities, you actually have to work on that and building a set of structures that actually work for everyone and not just for some people. If you talked about food and healthy food, but let's just talk about access to food right now, healthy or not, just access to food. So they're doing things like in Winfield, they're having places where you can go and get food. Well, that's awesome if you can get to Winfield, right? But most of the places where you have these food drives set up are far flung from the communities we're talking about. So even no matter what they're giving out, you want that food because you might not have access to food, but how do you get there even right now? And again, if you have people involved who are in this decision making, you might have these things lay out different. And that really becomes the central point in the crisis that, or the thing that we call a crisis that is happening right now.
Yeah, you're very right. So I think these crises are really the challenge. The other issue is that if you are in the low opportunity area in the state of Connecticut, the likelihood of coming out of that is far less in the entire region. I mean, there's studies after studies, and you look at those studies, and your heart is broken, and then you say you're going to try to fix it, and then you are not able to because there are not enough people who realize and wake up to it. And my hope and my prayer is that if anything good can come out of this pandemic, is there should be an awakening that, look, all these people who have been saying all these things are right, and now you're seeing so much death and misery and challenge and diseases that may make us wake us up and say, you know what, let's change the policies and then try to prevent people from dying at such a young age, and have an impact, and recharge and re-strategize. And these are policy issues. These are structural policy issues, and that can be fixed. And that is the frustration of the whole thing. Or I know you, because I've heard you, and for me as well, because I'm seeing all of this in the last many years. This could be fixed. Housing is a big issue that we'll have to look at. I think we have to change the prism in the post-pandemic era to say what can be done to be ready for anything else that happened, and also the daily deaths that we've been seeing in the communities at a much different rate than the others. So that's going to be the issues we'll look at.
Yeah, it is an extreme frustration of mine. I remember just very short while ago, the legislature engaged in a battle over 830G, which is a perennial fight. Um, and the legislature, in a bipartisan manner, decided from my perspective, walk backwards on 830G. Um, and what they wound up doing by making this decision, and I want to remind people, it's a decision. It's not like it had to happen. It's not a natural thing. What they did by making this decision was further lock people into the communities that they were already locked into, in terms of ability to get to housing. But the issue is that there's a fight within communities like New Haven and Hartford for affordable housing. Great. But there needs to also be a fight that talks about housing and what we tend to term high opportunity areas. But when you engage in that battle, you get shut down very quickly by people who will tell you, but I do care about these populations. The two things don't go together. You can't honestly care about these populations and lock them into places where the schools don't function the same, where access to stores for food aren't the same, and all the things we've been talking about. And here it is playing out right now. If you look at what's happening with school as we are remotely, a lot of people are talking about, well, do they have access to the Chromebooks? But there's a difference, even if you have the Chromebook, whether you're getting educated in the terms like an online class where the teacher's actually teaching, or if you're still just being given information that might as well be the package, right? And so there is a difference because of where people live as to what is happening with their children right now in their education system. And we talk about the summer slide, right? That we normally see. Hey, there's a summer slide and children fall backwards. Well, if we're concerned about that, we've had children locked in an education system where they're not being educated right now for 2 months. At the end of this month, it'll be near 3 months. And we don't know what's going to happen in the fall. Well, what are we doing about that? But that's not because of COVID. That's because of decisions we've been making this whole time. And one of the things I think has to be made resonant with people is that this is what you're seeing is just, you're seeing it, but it's been happening this whole time. And while you have gone to sleep and felt good about your life, because you're not on the wrong side of that equation. They're people who've always been on the wrong side of that equation. And if you keep letting them stay on that wrong side of that equation, when the next time this happens, you'll be standing there saying, my goodness, I can't believe this is what's happening. Someone needs to do something. What I'm saying to the audience, whoever is one person, 25 people, 2,000 people, that someone is you. You have to stand up and demand of your government that they do not allow these structures to exist as they are, even if the structures benefit you.
Yeah. Amen. Amen. So let me go through the health issues, the comorbidities or the illnesses that you're seeing. And I actually started off by saying that they are by design because the opportunity for healthy food and healthy nutrition is not there. Healthy living is not there. So we know that hypertension is more in African Americans, and we know diabetes is more in African Americans. And in some of the, as the people age, the obesity risk increases. And that is because of the fact that the access to healthy aging, healthy living is not as easily available or not available at all in many of the areas. Unfortunately, this disease seems to become worse. And that's the second part. So one is that it spreads more so in the community because of the physical reasons. The second is the disease actually progresses when people are infected. So it's an equal opportunity infector if you're in close contact, but it's not an equal opportunity progressor, because if you have an illness, if your weight is on the higher side, if you're a smoker, if you have diabetes, if you have hypertension, if you have heart disease, there's a difference in there. And the African American community, because of the systemic issues that we have discussed, are at a higher risk of those things by design of the society, the design of that. And therefore, the disease becomes a much more significant and a severe disease in those cases. We
Yeah.
saw the same thing in Chinese, the ones who were with the hypertension, diabetes, and so on. We saw these in Italians, the Germans, and so on. But in the US, because there's a disproportionate number of people in the African Americans who have diabetes, hypertension, as well as smoking, as well as obesity in some of the segments, they actually become a higher risk group just from that and that alone. So that's a big issue. And
Yeah.
then the third group, another category is the environmental determinants. So the micronutrients are not the same. Vitamin D levels is different. So of course, when your skin is a little darker and you are in the northern part of the hemisphere, you are not going to get as much of the vitamin D. So there is now more and more understanding that the vitamin, and we have vitamin D studies on the Latino community and the African American community. It is highest, thankfully, in the white community, but the other communities have not been getting as much of it through the natural means or through supplementation, and therefore their risk of respiratory infection is higher. And now in this particular case, it is suspected that the low vitamin D is contributing to that. And this would be a good opportunity to tell people that, look, vitamin D is available in the supplement places as well as the supermarkets. Start to have the vitamin D supplements that you can. And that may be a way of reducing the risk a little bit of the progression of the disease. So that's something is worthy to look at.
Yeah, but then again, I mean, if you think about that, you potentially have a cost factor there as well. But I just want to say that one of the ways, as you suggested, you can get vitamin D is by being outside, right? The message is don't be outside, and also the message is when you're outside and you're Black, you're more likely to run into trouble because of COVID-19. We see that in parts of New York and in some other parts of the country, and so there's a deterrent effect of going outside, whereas other people might feel free to go outside and walk. When I go outside, I have to think about, does this actually have a meaning that is more significant than I went around a block for a walk? And I think that's important because I don't think that's something that people are thinking about. Even you can take that and extend that to the conversation we were having initially about even wearing a mask. And I told a story on the call with the Senate Democrats that as well known as I am, and I've discovered that even my eyes are well known at this point, but as well known as I am, I was reticent to wear a mask because I know what it means for a Black man to be walking around with a mask in public. And again, this just goes to the notion that I've been trying to impress upon people, that those are things that are almost inherent in my mind as part of like a response to this, right? Like it just, I don't need anyone to tell me that because I've experienced that. And the people who are making decisions, they get told that eventually, but they don't. It's not part of the initial decision making. And if you don't have people who are part of the initial decision making, then there has to be an effort to fight the message up that shouldn't have to happen. That these things should be part of what is being heard by the people who are making decisions from the beginning.
Yeah, yeah, you're right. As I was looking through some of the lists, in the beginning when we were managing some of the illnesses, we were using hydroxychloroquine, and we were using Zithromax, these antibiotics initially, because some of the data initially was suggesting that there would be a benefit. The risk of heart arrhythmias is a little bit higher in the African Americans with these medicines. So it has not been proven, but it has been suggested that that may be a contributing factor too. So those are, there's environmental issues, there are a little bit of genetic issues, there are social issues as well. Just also mentioned in I think it was in New York, there was a park that they looked at the citations, and for the citations for social distancing not being followed was much higher in the African American community. Now, would that be related to the same family members being around or not? They did not explain that part as well. But the social distancing is more of a challenge in communities because of the way the structure in those neighborhoods is. It's very difficult to be able to do that.
But I think it's important to remember, regardless of why, whether it was a family, whether it was friends, whether it just happened to be a lot of people, whatever, I think there's a message that's sent, right? So you watch on television people going out and they're protesting and they're gathering, and they seem to be certainly less than 6 feet. You watch communities go out and have even celebrations we've seen during this thing. You watch all of this stuff play out. And then when you open your paper, either today or yesterday, you see that 90% of the citations that happened were for Black people. That sends a message to Black people that your government is functioning in a way you have always understood it to function, and you don't get treated the same. And so you need not be out there, because you're not going to get the same response from government. The response you're going to get is you're going to be cited, you're going to be arrested, and that is highly problematic. The messages we send cause the responses we get from these communities. And then when the communities respond as they do, saying, well, if I do this, this is how government is going to respond. What people say is, well, why do you think that? They think that because we have an actual history of operating differently towards these communities. And you are seeing it right now.
Mm. That's so true. So now, looking at, if we understand and the things that we have seen, what do we do? What is the treatment? What is going to be the new tomorrow like? And that is something that I think we will all have to, everybody will have to put their thinking hats on. And this is where we'll have to figure out the healthcare. First of all, healthy living opportunities is a right. When we say healthcare is a right, healthy living opportunity is a right. Why is it that we have food desert? Why is it that somebody who wants to be healthy, why is it that somebody who wants to breathe good air is unable to do so in some of the communities? What do we need to do structurally from a policy end to make it easier and have the opportunities for people to be able to live in a healthier environment and financially better environment? Now, we are talking about sustainability of our state. The sustainability of the economy of our state is linked to doing the right things. I'll give you one example. They looked at the changes of young children and their families were able to move from a low opportunity area to a high opportunity area. If the child was less than 8 years of age, and when you compared the children when they grew up about their capacity to be successful, they were equal. Equal. So when some of our children or many of our children are left behind, we as a state, we as a country do poorly. Right. And the children are fully capable, equally capable of being at top of every game that they can be. So the structures are restricting them. And as a result of that, we are actually not having the workforce of the capacity that we need to have. We are not getting the scientists that we need to have. We're not getting the every field that you can imagine is hurting because we are leaving people behind, and then we're selling ourselves short.
Abs- Absolutely. And I think that's, my the work that I've been doing for a long time has been to try to figure out how to get people to understand that. And also because that's a very difficult thing to do, how to put it in terms that people recognize these as their issues, even if they don't see them. So if you step back to around 2006, I was doing some work around education, and realized that the workforce in this state was going to be much more black and brown than it was around 2006. By the time we got to, at that time, we were actually looking at 2020, which seemed like a long way away. And that had some ability to get us into the conversation. But I think a lot of people look at these things and they don't see themselves in the issue. And so it's okay to allow for the things that we've seen. Several years ago, I was doing some work around getting the state to do a new disparity study, because economics are important, and access to some of the contracts that come from the state are important, and all of the things we know. And what government was saying was, even though we have a sense that there's a difference, the disparity we had was 20 plus years old and it wouldn't stand up in court and all of these things. And so I did the work of figuring out what that disparity study would look like, what it would cost, and not just guessing at this, but doing real deep work. Came to the legislature, presented this. We were talking about $2 or $3 million. That got shut down, and they shuffled it off to this outfit that could not do the work, and we still don't have the disparity study done. That has longstanding implications. Why that is on my mind right now is because we started off this conversation talking about the consulting group. And in the middle of this, a consulting group that has no experience with COVID-19 was given $2 million. But we can't find $2 million to do a disparity study that will fundamentally change the lives of whole communities in the state of Connecticut. Those are policy decisions that build the structures upon which people's lives exist. That's the kind of thing that we have to change. So this is not just the kind of thing where people are just talking and theorizing. This is real. When we make certain decisions, we have a huge impact on lives, and we say we can't do it because we can't find the money, and yet we found $2 million to give to a consulting group to do I don't know what.
Yeah. I have my students I teach when we have residents and medical students who come to the intensive care unit with my rotation. And sometimes when I'm in the ICU, I'm seeing a patient and I look at that patient, and that patient has a disease. But what I say to them is that this patient is a symptom of what is wrong with our state. And they're looking at me like I'm crazy. And I say, this patient does not belong to be in the ICU. This patient should have been healthy and well out of this ICU and at home with his family or her family.
Yeah.
It is our failure at so many levels as our society that has resulted in us seeing that patient in the ICU. By that time, it's a little too late. And this could not be more true for COVID-19 with all the patients that I'm seeing of the different communities. Majority of them are minority, but it's others as well. And these are all preventable, truly preventable. And then that's the heartbreaking part of this whole situation, is that this is preventable. We failed. Now we have to have a strategy going forward and say, you know what? We have had a pandemic. It took us over 102 years to see something of this capacity. Is it time you wake up and then start to have a new beginning and do the things right? Start to work in the housing opportunity, look at the education opportunity, look at economic development opportunities, look at the healthcare access to people, look at healthy living opportunities. We will have to go back to the drawing board to become a more focused community as a society, as a state, so that the economy is going to go up. Anytime any policymaker in any part of the world wants to leave a segment of the population behind, you are creating a cancer for yourself and your well-being. And that's the important part. And I hope this would be a way we can actually get the message out through this conversation and more conversation, Gary, to wake up and do this. And this is the time for a new resolve. And we need to wake up and do this together. And I know you're there. I'm just your friend and your partner in this, but we'll have to get more people on board to do this.
Yeah, I just, before we're done, I just want to reflect on what you just said. You just said that if we do these things, we are creating a cancer. I want people who hear this to think about that, because that is true, right? We have choices we can make. If we make a choice, if we choose to do this thing in the way that we have been doing it, we are creating the cancer that will destroy us, not destroy someone else, right? It feels like it's going to be someone else, but we are creating the cancer that will destroy us. You started this off talking about the work that I've done. I just want to say this to you. I am so happy that you are in the state Senate. Um, the work that you are doing during this and the choices that you're making to stand up and say what needs to be said are critical. I watched you when the governor brought you on, and there was a choice for you to make there, right? There's absolutely a choice for you to make, given the place where you are and how you were brought into that conversation. And you made a choice that not everybody would have made, to talk about what the real impacts of certain decisions are. That is how we change these things. We change these things when people make the choice to say what is real, despite the fact that it may not be the most comfortable or opportune time to do so. And so I just want to thank you for, one, reaching out to me, two, being there, but more important than that, making the choice to say what needs to be said so that people can hear it in ways they're not going to hear it, because that is how we make this change.
Man, thank you so much, Gary. Thank you. Let's make this happen now.
All right. Thank you.
Thank you.